Hello everyone. Today I'll be talking about GATT, which is gonioscopy assisted transluminal trabeculotomy, and I will be sharing our experience and some tips about the technique. Minimally invasive glaucoma surgeries basically bypass the trabecular meshwork resistance, and the Schlems canal outflow pathway is improved. So basically they go through the collector channels into the episcleral veins. And this particular procedure has been popularized in early to moderate open-angle glaucomas, and we all know that there is some amount of IOP reduction and decrease in the number of anti-glaucoma medications. However, with the newer procedures being added and our better understanding, we are today able to offer these mix even in patients with a few of the patients with advanced glaucomas. It is very important to know that the angle structure should be very well visible for us to be able to perform this procedure. The trabecular meshwork should be identified either with the pigmented trabecular meshwork that we can see, or in lightly pigmented patients, blood in Schlems canal can act as a marker. Most of these trabecular and Schlems canal bypass procedures have something called a floor effect. So what does that mean? The intraocular pressure reduction with any of these procedures cannot go less than the episcleral venous pressure. Maximum number of these collector channels are present in the nasal location. So inferior nasal location and the superior nasal location have maximum number of these channels. Often glaucoma is a medically treated disease, and we offer surgery only in those situations where the pressures are uncontrolled, or the patient is non-compliant or not able to afford medications, or in those where despite our treatment, the disease is progressing. Which means that in several of those advanced glaucomas that we see in our country, if we choose a glaucoma procedure, it has to be time tested and should work longer. So we know in trabeculectomy over 20 years, this was a paper that was published in the recent times, which showed a 55% complete success rate at the end of 20 years. And with addition of anti-glaucoma medications, the success rate was as high as 88%. We all know that in secondary glaucomas, as well as in younger patients, the risk of scarring is much higher. Hence, the trabeculectomy may not function very well, and significant number of these patients may require additional surgeries. As alternatives, we do offer either glaucoma drainage devices or laser cyclophotocoagulation. And of late, we've been offering even mix in those patients where our primary trabeculectomies have failed. GATT is one such procedure which was introduced by Devinder Grover in the year 2014, and it shows great promise. This is for the beginners. So we need to be familiar with the angle anatomy. So doing a direct gonioscopy, maybe practicing it during cataract surgery is very useful. Understanding the positioning becomes very important. And one other thing that is important is use of a good viscoelastic. Preparation of the suture and availability, some of the companies do provide, but we can prepare them ourselves by using a heat cautery. So the tip of the suture, 5-0 Prolene suture, is blunted, but that tip should not be too big. If it is mushroomed too big, then it may not be comfortable to pass it through the Schlems canal. And sometimes if it is too large, we may not be able to pass it, or even if it passes, it can tear through the Schlems canal and there can be a false passage. Positioning of the patient's head, tilting the microscope, and ergonomics and the surgeon's positioning becomes very important. So we know the patient's head is tilted away from the surgeon, the microscope is tilted towards the surgeon, and the eyepieces are almost straightened, and the table height is often I'm comfortable if the table height is increased so that it becomes easier for the procedure to be performed. The most important prerequisite is the open angle, and one needs to identify the anatomical landmarks very well. So if you have a good pigmented trabecular meshwork, one will be able to easily identify it, but in the absence of pigmentation, blood in Schlems canal can act as a guide as well. A few steps that I would like to show in this procedure is that, so before performing, the incisions become very important. So use paracentesis to make 2 nasal incisions one nasal superior and one nasal inferior. Use an MVR plate to make an incision in the upper border of the Schlemm's canal and thread the Prolene suture into the goniotomy site. Sometimes we also make an incision in the clockwise direction, because that is not something that I'm comfortable with. First, we try and use since we're using a right hand, I prefer to use the inferior nasal incision to thread the suture, but sometimes we may do it in an opposite direction. But what is important is once you create a cleft and a goniotomy in the upper border of the pigmented trabecular meshwork, the Prolene suture can be passed through and you will be able to visualize a blue suture as it is going. So if you are able to see it very well, that means you are in the right position, and keep injecting viscoelastic to make sure that the globe is taut when you are trying to advance the suture. Because if the globe is soft, then we may create a false passage, and because of the folds on the cornea, it also becomes difficult to visualize. Once it passes 360 degree, one can hold the tip of the suture and with a second instrument try to, in a cross-action manner, rip the entire inner wall of the Schlemm's canal. So AC wash can be done. Some amount of viscoelastic can be left in the anterior chamber, or an air bubble can be left, and don't hesitate to suture if necessary. So the globe has to be kept taut so that there is no bleeding in the anterior chamber, or the bleeding can be minimized to a great extent. This procedure is also possible to perform even in eyes with failed trabeculectomies. With 360 degree GAT is also possible if the previous trabeculectomy ostium has not involved the trabecular meshwork area. Then a 360 degree GAT is also possible. In case in a situation where it is not possible to pass 360 degree, or the ostium is involving the trabecular meshwork, then a 200 or a 270 degree GAT or a 180 degree GAT is also possible. This is one such patient who was juvenile open angle glaucoma with 2 failed trabeculectomies. You can see 2 peripheral iridectomies that are there, flat bleb, and the trabecular meshwork is very clearly visible with ostium which is patent. So this patient underwent a GAT rather than performing a GDD. And post-operatively, you can see this patient had well-controlled intraocular pressures even at 2 years. And the ASOCT image actually shows a well-open cleft that was created during the GAT. It is also possible to perform the ab interno procedures in patients with previous failed GDDs as well. This was one such patient who had a young patient post-RD surgery with vitrectomy and belt buckle, underwent an implant that failed, and uncontrolled pressures required a GAT. And post the procedure, he has well-controlled intraocular pressures with one combination medication, and his discs and fields are stable. So this was one of our papers that we published on outcomes of GAT in eyes with prior failed glaucoma filtering surgeries with 82% qualified success rate at 15 months. Post-operative care of these patients become very important because these eyes are known to have very high steroid response. Hence, the frequency and the duration of steroids, I think one needs to be very careful with. I prefer to give topical steroids for a very short duration. If the procedure is combined with, if the GAT is combined with a phacoemulsification, I may give for about 2 weeks. Otherwise, less than a week is the topical steroid usage, depending on the hyphema. Topical NSAIDs we do use for a little longer time, and periodic gonioscopy in the postoperative period to not just look for the angle which is open or closed, but also presence of synechiae or blood in Schlemm's canal becomes important. ASOCT to look for trabecular shelf is another postoperative investigation that we do in these patients. I don't start pilocarpine on day 1 unless it is a eye with a prior shallow anterior chamber, or those eyes where there are occasional synechiae. Then you want to prevent the synechiae formation, hence pilocarpine can be given, but I prefer to give it after 1 week and up to 1 to 2 months in the postoperative period. Based on the intraocular pressure, I would start either a topical alpha agonist or a beta blocker to bring down the intraocular pressure. Hyphema is one of the common complications that we see. Sometimes it is very minimal or trace hyphema, or sometimes you can have aqueous mixed with blood, or in few instances we can have large hyphemas as is seen in this picture. Often they get absorbed and it drains out through the opening that we have created, and very, very rarely they may require an anterior chamber wash. Since we are manipulating in the angle, if one is not careful, either with the suture or with the goniotomy, one may create a cleft, and that cyclodialysis cleft can cause a problem in the postoperative period. So to summarize, GAT is definitely very promising in both primary and secondary open angle glaucomas, and it seems to be helpful even in patients with prior failed filtering surgeries, both trabeculectomy and GDD. Gonioscopy becomes very important preoperatively as well as intraoperatively, and of course in the postoperative period, to plan the surgery, to perform the surgery, as well as to follow up in the postoperative period. Intraocular pressure spikes can be a problem, that is a sudden rise in intraocular pressure because of either a steroid response or a hyphema is something that one needs to be aware of, and we also need to prognosticate and explain it to the patients as well. Follow-up becomes very important. Like I mentioned, postoperative gonioscopy and ASOCT of the angle to look for the cleft becomes important as we understand this procedure and to manage our patients better. Thank you so much for your attention.